Good evening. Welcome to the next in a series of significant contributors for FDS webinars. My name is Professor Jag Dander. I'm a Professor of Surgery and Consultant Head and Neck Surgeon at Brighton, and it's great honour that I want to introduce Professor Claire Stevens, who has kindly agreed to host and present on today's webinar as a significant contributor in paediatric dentistry. Now, Claire was appointed as a consultant in paediatric dentistry in June 2009. In fact, we were just talking fondly of our days in Bristol at the beginning of the century. She's a media spokesman for and a past president of the British Society of Paediatric Dentistry. She is involved in the Paediatric Dentistry Managed Clinical Network in Greater Manchester, which is a group that is working to improve children's oral health and paediatric dental services across Greater Manchester. In her bio, she writes the toothfairyblog.org, which is aimed at just providing some pragmatic evidence-based information to parents and children's oral health. So Claire was appointed with the CBE in the 2019 New Year's Honours List for services to children. She works as the clinical policy lead with the Office of the CDO and advises the National Medical Director for Children and Young People in Children's Oral Health. And she's also just recently been appointed an honorary clinical chair in August of this year. So Claire, thank you very much for giving us your time to give us on paediatric dentistry in a post-COVID world, a vision for children's oral health presentation on paediatric dentistry in a post-COVID world, a vision for children's. Delighted to have you here. Quite a big audience today, and look forward to hearing your presentation. I'll compose these to Claire at the end of the webinar. And we'll touch base again in about 45 minutes when she finishes. So over to you, Claire. Thank you very much again.
Thank you, Jag, and thank you, in fact, to the whole RCS team and all the organisers for inviting me to be with you today. It was really quite. I was really quite touched to be invited to join you, and thank also for you being here in an evening, because I know that time after work and busy clinics is extremely precious. So thank you for joining us. So I'm hoping that if we do this right, the plan of action for today is that I'm going to speak to you for around sort of 40-45 minutes, and I've added a couple of learning objectives from the initial brief just because things have changed and I wanted to keep it totally fresh and up to date, and then I'll be happy to answer any questions you have. I won't be looking at the chat whilst I'm speaking to you, but I will do so at the end, and I know Fatima and the RCS team will be there to facilitate questions as well, so please ask away. So for those of you that will have heard me speak before, you might have seen this jar of teeth because, as Jag said, I'm an NHS consultant in paediatric dentistry, and my Wednesday afternoon on a slide looks something like this. So in this jar there are nearly 200 teeth, nearly 100 teeth, including 20 teeth from 1 2-year-old child. And on the left is an operating list, a fairly standard operating list. It could be any week, with each of those numbers representing a decayed tooth removed from a young child. So we know the figures behind paediatric dental general anaesthesia. Pre-COVID, around 45,000 children were having removal of decayed teeth every year under a general anaesthetic. That's at a rate of around 1 every 10 minutes. It's still the most common reason for a 5 to 9-year-old child to be admitted to a hospital in this country. And that's at a significant cost to the NHS, to the tune of around £50.5 million every year, and of course to the child and the families. And the frustrating thing is that this is for a disease which is almost always preventable. But my personal bugbear is the persistent and immoral inequalities that we see in children's oral health, with children coming from lower socioeconomic groups almost twice as likely to have decay, more likely to experience toothache, more likely to have difficulty in finding an NHS dentist, and more likely to report that their poor oral health is impacting on their daily lives. We also know that there are inequalities by geographical region, and where I work in the Northwest, we have 50% of our children in Oldham, for example, starting school with visible dental decay. But COVID has made things worse. And I want to spend a couple of slides just talking about the impact of COVID on children and young people. So the data I'm going to show you now is not my own. It was collected by David Landis, who is a consultant in dental public health and far cleverer than I. And what he did is he looked at middle layer super output areas. So what we need to know about this, for those of us that aren't expert in these type of statistics, is these are a size of geographical area where there are enough residents or to make it that the data can be looked at is significant. And what David did is he looked at NHS dental services attendance and what in two periods. One was a pre-COVID period, so July to December 2019, and one was a peri-COVID period, so July to December 2020. We picked the same months of the year so that we didn't have any seasonal variation. The data is from the northeastern Cumbria, but having seen the national data set, it's pretty much identical. And what he then did is looked at accessing NHS dental services and mapped this to known and agreed indices of poverty and deprivation. So what did he find? Well, the two different graphs here look at the pre and the post-COVID. So pre and peri-COVID. Pre-period is green and peri-COVID is red. And then as you're moving along the x-axis, the families are becoming more affluent. So we know from David's data and other data sets that COVID has had a disproportionate effect on young children, those from lower socioeconomic groups, and also those from Black and minority ethnic groups. We also know that there was in March 2020 cessation of routine face-to-face dental care, and in a secondary care setting, reduced access to general anaesthesia, partly due to redeployment of our specialist teams, but also due to repurposing of theatre environments to support the nationwide COVID response. In paediatric dentistry, this was an 85% reduction in activity recorded between March and April 2020. And of course, we have ongoing challenges due to the necessary infection prevention control guidelines. So the result of this is that we're seeing increased pressure on already stretched secondary care services, with current waiting times for general anaesthesia in excess of 18 months and in some parts of the country, 2 years. So what are we going to do? Well, I have been accused of being too optimistic, and it's a criticism that I will accept, but I do believe that out of every dark situation comes an opportunity. And for us in dentistry, and particularly in paediatric dentistry, I think we have an opportunity to build back not just better, but fairer. So for the rest of the presentation, I'm going to talk about these 9 areas of what I believe we should be looking at to improve children's oral health and my vision for our specialty. So firstly, it won't come as any surprise that my first slide is about prevention and starting well, because we know that dental disease is almost always preventable. Supervised toothbrushing in all early years settings would help to reduce the incidence of decay. But even if we could only look at getting that in the 30% most deprived areas, I think that would be a significant win and one we should all be aiming for. We need to look at interventions like community water fluoridation, and I'll talk about the return on investment piece as we move through the presentation. But certainly what is clear to me is that we're not going to achieve this by working in isolation. We need to ensure that we're engaging with all partners, so health visitors, school nurses, GPs, pharmacists, so that wherever that child should choose to access care, they are receiving consistent and evidence-based information. I also think we need to look at innovative approaches to how we deliver key oral health messages. With the new version of Delivering Better Oral Health due out next week, we have an opportunity to again reinvigorate the spread of these messages. So BSPD has been instrumental in pulling together different content which is optimized for sharing on social media. So here you're seeing a screenshot of our Kids Vids page, and we commissioned 4 videos and wrote the content for 4 visions in partnership with Brush DJ with Dr. Ranj, who many of you will know from his breakfast TV presentations, and also from Strictly Come Dancing and his own preschool focused work as a paediatrician. So some might say, well, why on earth would you have a paediatrician talking about teeth? Well, actually, it was an evidence-based decision because we completed some research in Manchester looking at the influences of parents of high-risk children. And what it showed us is that it's not dentists that are influencing parents, it's actually celebrity, it's actually sports personalities, it's actually people like Dr. Ranj, and actually he came top of our wish list because he seemed to have the crossover, the authenticity of being a paediatrician, but also the sort of power of celebrity as well. And it was just a delight that he was able to work with us to produce these 4 videos. One is about dental check by one, and then there are 3 aligned to the different age groups in delivering better oral health. These are free to share. Please use them on social media. They're only 2 minutes long. And you can also use them on practice websites, or you can send, refer your patients to have a look at them and signpost to them. And I should acknowledge the generous funding of both Henry Schein and Dentizan, without whom this project would not have taken place. And my other interest in terms of prevention is around the use of health tech and digital technology to deliver standardised messaging. Because this graphic on the left, I think, says it all. Actually, 6-year-olds better understand digital technology than many of the adults in their household. I know it's certainly true in my family. My 6-year-old son can code, he can design his own games, and if his grandma gets confused about how to work her phone, then he can usually fix it for her. He's grown up as a digital native, so it's second nature to him. Also, I have done quite a lot of work looking at how we work with media which is parent-facing or designed to be co-watched. And here in the picture at the top is my daughter Ava when she was 2. She's now nearly 9, so it shows how long I've been going on this journey. And we did My First Dentist. So we looked at delivering key messages from Delivering Better Oral Health, incorporated as part of a known brand of My First, where a child gets to do different firsts each time, my first day at school, my first getting my glasses, and they wanted to do my first dental extraction, but I persuaded them that it should be my first dental visit instead. And that again is available to view on BSPD's YouTube channel. At the bottom here we have Hey Dougie's toothbrushing badge, and this is my concept that I put forward to the producers of the show, and after some discussion they agreed to take it forward. And the result is Hey Dougie's toothbrushing badge, which has been seen by tens of millions of families worldwide. So my second point is around dental check by one, and everyone that has heard me speak will probably know that I include a reference to Dental Check by One in pretty much every presentation I give, because it's my passion, and it was the initiative that I led during my term as president of British Society of Paediatric Dentistry. And this is focusing on the principle that every child should be able to access preventatively focused NHS dental services as soon as teeth come through or by their first birthday. And when we launched Dental Check by One, the following year, we saw a 23% increase in 0 to 2-year-old children accessing NHS dental care. But there's understandably been a pause as a result of COVID, but really, we really must refresh it and reinvigorate it as a campaign. And if you want to have a look at any of our resources, look at dentalcheckbyone.co.uk. It's got a separate website. All the resources are there. There's a separate blog as well, and we'd love to hear how you use them in your practices. Thirdly, there's been a rethink, I think understandably, in light of the pandemic, that we need to move towards minimally invasive oral health care while still prescribing interventions that have known evidence base and are acceptable to patients and their parents. So the 2 I wanted to signpost to you today are Hall crowns, or Hall technique I should say, and SDF, silver diamine fluoride. And the picture on the right here is an excerpt from a lovely little video which was the result of a joint grant between RCS and BSPD and produced by Laura Timms, one of our registrars in Sheffield. So what is SDF? Well, it's a colourless liquid. It's 38% SDF, is produced by Rivastar, who's currently, I believe, the only manufacturer in this country. And each SDF itself contains fluoride, around double the amount that you would see in Durafat, and also silver, which has an antibacterial effect. So the main action of SDF is to occlude the dentinal tubules, and that's why it's licensed for reduction of dentine sensitivity. But there is also a strong evidence base for its effectiveness in caries arrest. And as such, we have felt confident to include it in off-label use and recommended in standard operating procedures published by the Office of the Chief Dental Officer England in light of the COVID pandemic. But we were conscious that we were really pushing a technique that, whilst in widespread use overseas, was still up and coming within England, although it's been used by many of the teaching dental hospitals for some time. So BSPD made the decision to produce all of the resources we felt that colleagues in primary care would need in order to be able to adopt this as clinical practice. So if you go on BSPD website, bspd.co.uk, or even Google BSPD SDF, you should find this list of resources that I've put in the screenshot here. So there is the video I mentioned that has been made by children for children. It's great. I think they do a better job of explaining it than I do. There's also a patient information leaflet, which you can print. You can put your own trust logo on and you can use it within your own service. There's a standard operating procedure, again, which can be adaptable to your setting. A consent form, particularly to support you around using it off-label. And then there's also an SDF PowerPoint, which is really nice and short, around 6 minutes. It's kind of like a whistle-stop tour of everything you need to know, and also a short demonstration video of how to do it. But it really is simple. In summary, protect the lips, paint it on, jobs are good. So, the other technique I wanted to share with you is probably more familiar, and that is using pre-fall metal crowns using the Hall technique. All of the information that you need to be familiar with the Hall technique is in this manual. And actually the best way to find it is on the Wikipedia page for the Hall technique, because it's actually been written by the authors and everything is really nicely up to date. And that's a really good way of making sure you're getting the latest version of a manual. So for those that are not so familiar with it or currently need some persuasion to adopt it in their practice, this is a technique which was devised by a GDP in Scotland, Norna Hall, and essentially it's placing a pre-fall metal crown without preparation, without local anaesthetic, just squeezing it onto the top of the tooth, which might sound, crazy when you first think about it, but actually it's employing all of the principles of biological caries management, which we know and trust. So there is high acceptability to everyone involved in the process, to children, to their carers, and to the general dental practitioners who are placing them. And after 2 years, placing Hall porcelain pre-fall metal crowns showed more favourable outcomes for pulpal health than and also restoration longevity than conventional restorations. There are now 5 randomised clinical trials, and if you want to see them again, they're listed in this manual and available on the Wikipedia page. So for me, the combination of enhanced prevention delivered in different ways and minimally invasive oral healthcare using Hall technique and SDF is the mainstay of our treatment as we emerge from the pandemic. Why? Because it can all be delivered as a non-AGP. And I'm not going to get into a discussion around AGP versus non-AGP, because I don't think it's, for me, it's much more about a sliding scale, so a higher AGP generating procedure versus a lower. But really, if we can minimise this, the need for AGPs for the time being, it's certainly going to make things easier in terms of spread of disease. So my fourth point is about oral health inequalities, and I have talked about it in earlier slides and why it matters to me. And for me, this is really the time to do something about it, because we now have a new directorate within the NHS England and Improvement that is specifically focused on health inequalities, and a very formidable director. And so with their support, I feel empowered to make these suggestions for us as a specialty and also for us as a profession. So first thing is that we need to improve the data that we hold. This isn't pie in the sky. This is actually included in NHS Ops planning guidance. We should be recording ethnicity coding for all patients referred into our services and for waiting lists. Why? Because we need to show that we offer an equitable service that is accessible to all and delivers optimal outcomes and a great experience for everybody. And we can't show that we do that unless we collect the data to prove it. So that's something that you will see coming in over the next year or so, and perhaps sooner if you're working in an acute trust. Secondly, we have an oral health indicator now included in the Health Inequalities Dashboard. Why does this matter? Because it now reports oral health amongst other health inequalities, and it means that we're reported in the same way with the same resource to address it. We need to use data to drive a hyperlocal approach, and by that I mean really understanding the populations we serve, almost down to a few streets or postcodes. And we can learn a lot from the uptake of the vaccine for COVID, where teams, for example, in Bolton, realised that there was low vaccine uptake, vaccine hesitancy within certain populations. And what they did is went to those areas and worked with community leaders, and it turned out to be faith leaders, to actually understand the vaccine hesitancy and then put measures in place to support the community to be vaccinated if that's what they wanted. So, for example, you will have seen vaccine clinics set up in places of worship and community engagement in order to deliver that. And it had a phenomenally successful approach. And I just thought, actually, there's quite a lot that we can learn from in terms of paediatric dentistry, because we will have pockets of really high need, and at the minute we don't really target interventions at them. So we need to identify high-risk children, and once we identify them, we need to deliver evidence-based interventions. And that, for example, a child's coming for a general anaesthetic, we should be looking at reducing their frequency of recall, but we also should be looking at other members of the family, because it's likely that they will have experienced the same risk factors in terms of their oral health. So if we see a child coming in, you know, with and their sibling is sitting in the pushchair with a bottle of Ribena, we can't be turning a blind eye. We need to be putting measures in place for that child as well. And of course, these interventions should be in line with delivering better oral health. I'd also like to see equality and diversity training taking place across the profession, because I still feel we have a long way to go in terms of how we operate and how at times we don't feel as inclusive and diverse as we could be. And I don't think that's necessarily deliberate. I think a lot of it stems from unconscious bias, where we have a natural position where we will identify with people, whether that's colleagues or patients, that look like us and have a similar background to us. And in terms of patients, you know, it could be that actually there's what we call an affinity bias. So looking at, you know, if you have a patient that comes in to see you, their child is in pain, and you really kind of get on with them, you feel like you've got on with them, they're probably quite like you, a similar background, and would look fairly similar to you. It may be that without realising, you prioritise their care, like, oh yeah, we do have a long list, but actually I'll see if I can get you in a cancellation. Whereas for many reasons, families might not feel able to do that if there are, say, cultural differences. And we've certainly seen that in terms of GA waiting lists, where as we've gone through the waiting list to see how our patients are doing, we've found some patients near the top of our list who are there, white, middle class, and able really easily to advocate for their children, and some from some Asian communities particularly, who have sat there with a child in pain having multiple courses of antibiotics, and the response is, I didn't want to bother you, I know you're busy. So we do have these cultural differences which we need to address in the profession. Looking medically, a child born to a Black mother is 4 to 5 times more likely to die in childbirth than one born to a white mother. And yet, if you change the ethnicity of a physician to being a Black physician, that inequality is significantly reduced. So there is hard data out there that we still have challenges, and these apply to dentistry as well. We also need to look at reasonable adjustments, and by this I mean small things that we can do to make our services more accessible to all. So if we're thinking about, for example, a child with learning disability or autism, it may be that they would prefer to be seen earlier in the day. They might prefer not to wait in a busy waiting room, but to be able to come straight in from the car. And they might prefer to see the same clinician in the same surgery so that they are coming into a known environment. These things aren't necessarily expensive. There might be no cost at all, but actually they may make our services more accessible to all. And finally, I think we need to work harder to reach the traditionally termed hard to reach communities. I don't think we can put the blame on those communities. We need to look actively at how we can support them. So my fifth point is around focusing on caring for vulnerable children. And my role within the Office of the Chief Dental Officer is to provide clinical leadership to a project outlined in the long-term plan, jointly with my colleague Ush Devalia. So the long-term plan, published in 2019, outlines a commitment to deliver hearing, sight and dental checks to children and young people with a learning disability, autism or both in special residential schools. It's quite a mouthful, isn't it, and quite specific. But really the key point here is that oral health and quality oral health care should be a right and not just a privilege. So what do we know about children in these settings? Well, the first survey in these settings in England was completed by Public Health England a few years ago now. And essentially it tells us that children in special educational settings have a greater severity and extent of tooth decay in comparison to their mainstream peers, and almost double levels of visible plaque. They're more likely to have higher numbers of teeth affected by decay, and they're more likely to have teeth removed. So we know that there is a real need for improved dental services that are accessible for these patients, and that there is going to be a really important role to prevention. So what are we doing? Well, we are looking at an oral health initiative in special educational settings. That's what SES stands for. And you can think of it in 2 parts. The first is about an oral health check, so identifying that child's need and then signposting them to services, the right service, first time in the right place, and also giving them access to urgent dental care. And the second is the prevention activities, which we're completing under the Mini Mouthcare Matters umbrella. Now, I know that Mini Mouthcare Matters will be familiar to many of you. It initially started as the initiative to improve mouth care for children in hospital inpatient settings. But it's now become far more than that due to the dynamic leadership of Ush Devalia. And Ush has seen that actually there's a lot of learning we could get from the initial Mini Mouthcare Matters work, and we're now using this in our special educational settings. So what does our process look like? Well, first of all, there is Mini Mouthcare Matters training for the care and school staff. And instead of using a face-to-face model that was used in the Mini Mouthcare Matters version 1, we are now doing this virtually. So it allows us to upscale and spread at pace. There's training on how to complete a mouth check and a daily record, and then also training for the dental teams. And notice I'm saying dental teams and not dentists, because this is something that can be delivered by the whole dental team. And we wanted to support them because we realised in our early work that actually there's quite a lack of confidence in primary care dental teams in how they would manage children and young people with learning disabilities and autism. So we provided additional training and support and also explained how to complete a remote oral health check-in. There's then a pre-appointment with medical and dental questionnaires which are completed by the school and shared with the dental team. So the care staff who know that child the best will complete information about their medical health, and also they'll answer questions to help inform the triaging process. There's then a remote oral health check-in where the young person themselves, their carer, and then on the other end, the dental team meet to go through the questionnaires which have been completed in advance, and also, if possible, to look in that child's mouth and to decide where they are in terms of likely risk assessment. So this is a RAG rating, red, amber and green. So for example, in the red category, you could have a patient that was self-harming and had a clearly identified dental need. It's quite clear that that child needs face-to-face assessment. In the amber category, you might have a child that appears to be well, no dental issues have been flagged, they might have seen a dentist relatively recently, so they have a dental home, but perhaps they don't have daily mouth care taking place. So everything's not quite perfect. And it may be that we can provide support remotely to be able to move that patient to green at their next review. A green patient is one where pretty much everything is placed. So they have a dental home, they've seen that dental team fairly recently within the last year, and they also have a mouth care plan in place and mouth care is being delivered. So the action that we take is based on that risk rating, and it, as in any risk rating, it can be adjusted as new information comes to light. So my sixth point in terms of our vision for children's oral health is about looking at innovative models of care, but basing these on good data. So one thing that we've done in Greater Manchester is create child-friendly dental practices. At the minute we have 3 taking part in our pilot. We're hoping to move to 10, so we have 1 in every locality, and then 100 across Greater Manchester. So we have 10 practices in each of the 10 localities. And what we're doing is using the current contract, but flexible commissioning. So we top up that contract value and we ask our GDPs to undertake e-learning and then to provide evidence-based, minimally invasive oral health care. And there's quality assurance and peer review provided by both the managed clinical network and also the LDN. And what we're finding is that actually it's been super successful, and with support and training, our primary care colleagues have been able to intercept over 90% of children that would otherwise have found themselves in a secondary care service. We've found that we almost need to commission 2 separate models. So one would be an urgent care model. So for example, an 8-year-old child with 8 decayed teeth, but only one of those is symptomatic and requiring extraction. It may be that if that GDP can't render a child dentally fit, they could provide the urgent care of removing the symptomatic tooth, then enhance prevention in line with delivering better oral health and stabilisation, so that then as part of phased treatment, they might be eligible for rehabilitation a few months down the line. The second part would be rehabilitation, and again, using Hall technique, SDF, and restoration of teeth as required, along with the prevention activities. I think the key thing here is that this isn't happening on the current contract as it is. We are flexing it to contractually enable our colleagues to provide the care that we need for our patients. And it's been absolutely critical in helping us to manage the backlog that we have in secondary care, because we've not got so many new patients coming in to manage as well. The other innovative model that we're trialling, and a similar thing is about to happen in London too, is the concept of high volume, low complexity hubs. These are essentially areas which come together. So for example, across Greater Manchester, we might pool resources from our acute trusts and our community dental services, and perhaps even experienced GDPs too, to be able to staff operating theatres which become experts at delivering lots and lots of extractions with as great efficiency as possible. We started doing it just within my own trust at the time being, without you know, merging our resources and our patients for the whole of Greater Manchester. And so far, so good. We've also looked at different staffing models. So, for example, we now have 2 anaesthetic teams being trialled with 1 dental team, so that as one child is anaesthetised, comes into theatre, is operated on, as that child goes through to recovery with the same anaesthetic team, a second team is bringing in another patient to be anaesthetised, so that there is literally no downtime for the dental team between procedures. And we anticipate that we can almost double the efficiency of the number of children that we've seen on each of these lists using this model. We've talked a little bit about prevention, and I just wanted to remind you of this infographic, which I come back to time and time again, because when we are looking at what to commission, we need to make sure it's evidence-based. Sometimes I see, you know, really lovely stories of GDPs enthusiastically going into local schools to provide oral health education. And they may feel good about that, the schools may enjoy it, but actually there's no evidence that it's going to result in oral health gains or indeed reduce any oral health inequalities. So we need to be clear that we would commission universal measures as well as targeted intervention for those most in need, but using interventions with known, ideally known return on investment and known evidence-based. I've talked about the hyperlocal approach, and I think it's relevant here. Something like community water fluoridation would happen at scale, and I do think it's part of the solution, particularly to minimise young children coming in for surgery, but actually something like a supervised toothbrushing programme could be taking place in a community setting as well as in school settings. Recovery and restoration of paediatric dental services. Don't worry, I'm not expecting you to read this document there. It's just so that I can show you what it looks like when you come to find it. So recovery and restoration is going to be a challenge. Perhaps that's the understatement of the presentation. And I have been in meetings where that has been estimated at needing to take up to 4 years for us to recover from COVID as a pandemic. And I don't think we're really out of it in terms of the impact just yet either. As an aside, I think that means also about our own recovery as individuals and as a profession, and looking after our own mental health and well-being as we recover services for our patients. But that's perhaps a topic for another lecture. So what do I think this looks like? Well, first of all, any waiting list that's held for paediatric dentistry should have been validated or should be in the process of being validated. And by that, I mean reviewing patients that are on the list, checking that they haven't received treatment elsewhere, checking that they still need the treatment for which they were listed. For example, you know, a 10-year-old patient that was listed 2 years previously for removal of deciduous teeth might have exfoliated those teeth and not require any further surgery. Or the child might have experienced discomfort and managed treatment under local anaesthetic or inhalational sedation. So it's important that we really have a validated list so we know the numbers of children we're talking about. Secondly, we're working on a process for welfare checks. So for patients that are waiting for a long time, we shouldn't just have them sitting there quietly or not quietly on a waiting list. We need to be checking in with them, checking that they are the same degree of urgency as when they were listed, and checking that there is safety netting information being given so they know what to do if they develop a facial swelling, they know what to do if they receive another course of antibiotics, and they know who to contact. The document I've shown as a screenshot is the surgical prioritisation for children and young people requiring paediatric dental treatment under general anaesthetic, and this was published earlier in the year. And why is this important? It is essentially bringing us in line with other paediatric surgical specialties. So it is defining how urgent any particular condition might be from a paediatric dental perspective. If you want to find it, Google surgical prioritisation paediatric dentistry, and the link from the Royal College website should pop up. So, for example, a child who's received 3 or more courses of antibiotics should be prioritised for care, and this clinical urgency trumps referral to treatment times. There's very clear direction in the Office of Chief Dental Officer policy about this. So if you're receiving 3 or more courses of antibiotics, that child would fall in the category of P2. Why does this matter? Firstly, it enables us to recover services fairly. So those that are clinically, those children that have a clinically urgent need are being prioritised for care, rather than just a child that might be waiting for a long time but actually be asymptomatic and not have a time-dependent treatment. Secondly, it makes sure that our patients are seen with a similar timeline to other paediatric surgical specialties, and that's not currently the case. So, for example, a child that is P2 awaiting an ENT procedure should have a similar waiting time for a P2 patient awaiting a P2 paediatric dental procedure. And only by aligning ourselves with the other surgical specialties do we allow ourselves and our waiting times and our patients to be compared with them. So it's very definitely a political move and a deliberate move. It also means that theatre capacity in many trusts is based on the number of P2 patients held by each specialty. So by accurately coding our patients, we can say, actually, we've got 35 children currently classified as P2, and we need this many lists in order to be able to help them. So it's worth a look. If you haven't seen it, it has been circulated to consultants in paediatric dentistry, the organisational delivery networks, the managed clinical network chairs, but it's freely available online, and every service should be using this. And finally, in my list of 9 is the need to integrate oral health into the children's and young people's agenda. What do I mean by this? Well, Sarah will be proud of me for putting her catchphrase into my presentation, putting the mouth back in the body. So it means not just looking at oral health in isolation, and not just fighting for oral health as dental teams, and not engaging with paediatricians, paediatric surgeons and others within the children's and young people services. For example, we have some new complex weight clinics which are going to be launched nationally within the Children's and Young People's Directorate. So these clinics will actively target children who are significantly overweight, and it will put a whole suite of resources around them in order to support their improvement in health. So straight away, I'm thinking, well, if you're already finding these children, and we know that there are so many risk factors in common with obesity and with oral health, then this is surely an opportunity for us to put in oral health measures around that child as well. And that's exactly what's going to happen. To bring you totally up to date, I'm screenshotting here the clinical bulletin, the primary care bulletin, which if you don't receive that, I would recommend you sign up for, even if you're not working in primary care, because it often offers lots of useful links in one place. And the bulletin, the latest bulletin, which was published on Tuesday, I think, is being signed by Sarah and Simon Kenny. Why am I telling you this? Because it's hugely significant. This is a National Medical Director for Children and Young People talking about children's oral health. And actually, I think as we come to the point where our integrated care systems assume their statutory responsibility in April of next year, we need to be organised and coordinated so that we can inform their priorities, and children's oral health needs to be right there on their agenda. And as part of this CYP agenda, I'd love to see a permanent home and a permanent commitment to mini mouthcare matters, because I think there's so much shared learning that we've gained from both the hospital settings and also now the special educational settings that can be shared, for example, to hospices, to health and justice settings, anywhere where almost we've got a captive audience in terms of our patients. And let's hope that that's what the future holds. So finally, I hope to leave on a positive, because although we have significant challenges in children's oral health, to a point where I don't think that we've had challenges at this level ever before, certainly not in my practicing time, I do believe that there is a door is opening, that actually people are listening, And I'm going to finish with this quote from my childhood and current idol, Dame Baroness Fluella Benjamin, because actually I think that if we all work together, then we can do something about this, and we can improve children's oral health and the inequalities that we see in our patients. So thank you. I'm happy, I'm pretty much bang on time, which is a miracle, but I'm happy to take any questions that you might have. Thank you for being here today.
Brilliant. Thank you very much, Claire. That's a wonderful presentation. I do have a few questions. We have 80 attendees in total, so that's a great attendance for the FDS webinars. So the first question is, I'd like to use SDF in my clinical practice, but I'm worried about using it off-label. What advice would you give?
Okay, so at the minute, SDF is currently licensed for use of dentine hypersensitivity, but we know that there is a very strong evidence base for its use as caries arrest. So what we tried to do for BSPD is to make sure that you have all the resources to guide you through that process, how to have that conversation with parents. It's all done for you in the SOP and the consent form, and you can use it with confidence off-label, even if that's something that you're not confident to do. We feel that confident about it, that it is included in clinical policy in terms of transition to recovery from the Office of the Chief Dental Officer. It's in all the specialty guidance published by the Royal College of Surgeons, and if anyone challenges you on your use, I will provide free expert medical legal support to explain why you have provided an evidence-based intervention that could quite likely reduce the need of one of your patients requiring a general anaesthetic, or certainly reduce the chance of them experiencing discomfort whilst they are waiting for treatment. So I feel confident that we can use it, and the good news is also that it will become cheaper to do so. So I think that they are going to launch from single-use capsules into a larger bottle, so that will make it a more cost-effective intervention. And also there may be, as the patent expires, which I think it does this year, but don't quote me on that, there will be more and more companies offering it as a product. Sorry. So watch this space.
Thank you very much, Claire. And what about the current NHS contract for children? Does it work, the NHS dental contract for children?
My personal view is that, and I have to state again, my personal view is that the current NHS dental contract does not work for children, but I think there are ways that we can make it work. And what we're seeing coming out of COVID is different examples of commissioning. So we talked about the child-friendly dental practices, for example. That's a way of making the current contract work for children. So whilst it wouldn't be what I would design or what I would wish for, whilst we are stuck with it, I think we need to find ways of making it work, and I do believe that that's possible, yes.
One final question. Can you tell me more about one of your projects, the future of the Mini-Mouth Care Matters? Where can you see that in the future?
Okay, so it's not my project. It's very much the brainchild of Ush Davalia, who is a consultant colleague in paediatric dentistry and based in the Eastman. But I am delighted to be able to support her wherever I can. Where I think it will go, if properly supported and funded, which is my hope for the project, is that I would love us to start to be able to roll it out into all of the settings where this learning can be shared. So we're already doing a pilot in hospices, and that's an area where children are often overlooked. And you know, I've had children who are on palliative end-of-life care who are unable to eat or drink because their carers are not confident about mouth care. And actually, with fairly simple support, we can really make a difference to those last few days of children and young people. And I think that would be hugely valuable. And it's something the team is actively exploring and indeed piloting. I think we should be looking at any setting in which children might be resident. So I've mentioned health and justice. where incidentally there are high populations of young people with learning disabilities as well. So there's so much learning that can be shared there. But even, for example, it can go also into the adult setting, so nursing homes, but that then becomes mouthcare matters rather than mini mouthcare matters. But I would love really just this philosophy that children's oral health is everybody's business, and that actually we're not going to be able to do it. There's not enough paediatric dentists to deliver this by ourselves. What we really need to do is to be able to gain the support of anyone that might be caring for a child in order to be able to improve the mouth care and the access to prevention activities that we know will work.
Super, thank you very much. I actually have a question from your colleague, Helen Rodd, OBE, who...
Oh, crikey, this is like back to being a vibe.
Well, firstly, just a thank you from Helen for such an inspiring and comprehensive presentation. What do you think are the main barriers for families not taking their children to the dentist by the age of 1?
Oh, I think there's lots of barriers, and we're slowly trying to work out what those are and break them down. And the fact that we were able to achieve a 23% increase in 1 year would suggest that it is achievable to do so. And the fact that we double the national average of dental check by 1 in Greater Manchester proves it is possible. So what do I think those barriers are? First of all, I think that there is a lack of consistent information and messaging about when a first dental check should take place. So, you know, I remember as a new parent hearing a very unqualified and not in any way dentally qualified mum clearly advising another mum that they should wait until their child was school age. There was no point going before then. So there's a lot of misinformation, and that needs to be countered with clear and consistent information in ways that are accessible to the patients that we want to reach. So that's why there is the Dental Check by 1 video, and that's been, I'm not sure how many times that's been seen, but we're into tens of thousands now, so that's been great. The other thing I think originally, which I perceived to be a greater barrier than I think it really is around dentists' confidence in treating young children. But actually, I found that with not really a huge amount of support and sort of tips and you know, persuasion, but actually our primary care colleagues are more than capable of performing a dental check by 1. And once we get over this, you know, pressure that it's, you know, we must manage the examination, and, you know, against all odds, we have to do this, and actually realise it's about that acclimatisation to the dental environment, then I think that sort of eases the pressure on everyone. And certainly we found with webinars and peer review and including it in our Baby Teeth Do Matter training in Greater Manchester, and there was a real commitment to make it happen amongst our primary care colleagues. So I think it is possible. I think also we've touched upon the contract, but that again can be overcome with flexible commissioning, and in our child-friendly dental practices, it's part of the service specification that they have to commit to delivering dental checks by 1. So that is working. That does make a difference as well. And I think all of these things add up to the changes that we want to see. And then I think also now, you know, lives are busy. Lives are busy, and for some families they are very complex, and you know, getting across messages about NHS dental care being free for children are important, and also making those clinics accessible. So for example, one of my colleagues, Mohsen Ahmed, who is our LDN chair and just an amazing colleague, took it upon himself to go to weight management clinic, you know, baby weighing clinics, and he got so many new patients who he basically said, oh, you know, you're here in this health centre to have your baby weighed, how about popping in for a dental check by 1? And the convenience of it, the going to where the families were already going, worked really, really well. So I think we just need to rethink how we're doing it. What I don't expect is that I will give one talk or write one presentation or write one blog, and then suddenly everyone will come neatly filing into NHS dental services. I think we are going to have to look at different ways of delivering it. And in the latest bulletin, we also make it important that although we still have reduced capacity in primary care, we should be prioritising young children and the more vulnerable for dental recall. And so we now have the clinical guidance to support that as well. Thanks, Helen.
Super. Thank you. Just a couple of final comments. One from Alice Shaco. Thank you for a stimulating and encouraging update. All the buzzwords make sense now, and evidently there is much more detail behind them. I think these updates need to be fairly regular. So I think you've actually hit the nail on the head with achieving the main objectives of these webinars, and just to give us a new perspective and current perspectives in the various specialties of dentistry. And then finally, another final comment from Ush Devalia. Thank you so much, Claire, for all your vision, passion and support for mini MCM and children's oral health as a whole. Excellent presentation as always. So
it sounds like I planted that one, doesn't it? I didn't, I promise. Yeah. Thank you, Ish, and thank you for your drive and determination. And, you know, thank you, Jag, for inviting me to be here today. It's lovely to speak to everyone, and I'm really grateful for everyone giving up their time this evening.
Super, thank you very much. And on that note, we shall end the webinar. Thank you again, Claire, and have a good evening.
Thanks. Have a good evening, everyone.